Understanding Pain in Older Adults, Basics of Assessment. This is Module 2 in a series of training programs focused on improving the pain assessment and recognition in older people in nursing homes. This module is targeted for all nursing home staff who have the opportunity to come in contact with the older resident and be able to recognize and share information about their pain.
The objectives are to focus on the definition of pain, how pain occurs in individuals with dementia, to look at the difference between acute and chronic pain, to talk about myths about pain in older people. It can impact the way that we think about and respond to pain and pain behaviors, to define what are the important components of an evidence-based pain assessment and what we look for in observing for pain indicators. And then finally, to talk about the role of all of the team members in the nursing home, because each plays an important role in contributing to recognizing pain in our residents. So what is pain? Well, pain has been defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Although that sounds rather complex, what it's really saying is pain is more than a physical experience. It involves our emotions, our thinking processes, the way we feel, and it may have a real tissue damage origination or sometimes not. Sometimes it's very difficult for us to find the cause of pain, and it doesn't mean that pain isn't occurring just because there is no actual trauma or damage identified. I really like the definition from Margot McCaffrey that says that pain is anything the patient says it is. And it really is important to stress that pain is experienced by each individual differently. It's based on their unique experiences and how they perceive pain and experience it. And we can't, from the outside, know for sure how severe someone's pain is. We have to rely on what they tell us. And this is an important message for us to understand. When we think about pain in nursing homes, it's just really important for us to understand that up to 80% of residents in nursing homes have conditions that we know are painful and may be experiencing pain. That's the bulk of the people that you care for. But yet many residents' pain is not identified and they're not being treated. A study that was done looking at all 50 states' MDS medical records showed that only 15% of residents had documented daily pain. Of those with pain, what was sad was that 3-4 months later, 41% were still experiencing pain. And many of them that had excruciating pain, still not relieved in follow-up. So we really do need to focus on recognizing pain and then following up and making sure that we're providing effective treatment. In dementia, it's often thought that pain is less or it's not recognized and it's not treated. And a couple of studies on this slide illustrate that point. A study of nursing home residents, of 38 residents that had aggressive behavior. So they were combative, hitting out, resisting care. 60% of those residents had a diagnosis that we know causes pain, yet none of them were receiving any pain medication in the prior month. This isn't acceptable. In another study of 331 residents in both assisted living and nursing homes with dementia, a quarter of them did not have professional assessment, and 60% had no standardized assessment. And 20% of those that had pain were not getting treated. Again, it's a common finding that pain is not being identified and assessed, but if it is, patients are still not getting the treatment that they deserve. So we believe that addressing pain in older adults in the nursing home, particularly those with dementia, is a key problem and one that you can help with. There are many different problems that we know are painful, and residents in nursing homes experience many of these. And it's important for us all to be aware and thinking about whether or not someone is experiencing pain, especially if they can't report to us. And being aware of some of the things that cause pain, such as osteoarthritis and osteoporosis, nerve pain, such as that from shingles, from diabetes, diabetic neuropathy, phantom limb pain can be a real pain problem related to nerve issues and trauma. Cancer is a common cause of pain in the nursing home. And then just other conditions that we can actually treat can be very painful, such as unrecognized or untreated constipation, an infection, respiratory wound infection. So being aware and looking for these things is very important in the whole process. So what is acute pain and how is it different from chronic pain? Acute pain is pain that usually has a sudden start to it, and it's usually related to an illness or a trauma or an injury. And what's key is that when that trauma or injury heals, the pain should go away. So if we treat and if the cause of the pain heals, then the pain goes away. Chronic pain, different from acute pain, tends to come on more slowly, or it may follow acute pain. It is usually defined as pain that lasts more than 3 months. Some people say more than 6 months. Some people even define it as any pain that lasts after normal healing should have occurred for some type of an acute injury. And often we don't know the reason for chronic pain. So just because there may not be a diagnosis or a cause like osteoarthritis that's identifiable, the person can still experience chronic pain from conditions unknown. In fact, some people believe that chronic pain in itself is a diagnosis that deserves recognition and treatment. The goal of chronic pain care is to improve resident functioning and quality of life. Where in acute pain, we expect the pain to be completely managed and to go away. In chronic pain, it often doesn't go away, and it's something that we need to manage and treat to a level where the residents can have good quality of life and functioning, which is possible. There are many myths that impact how people think about pain in older people, and we want to talk about some of those. One myth is that all pain conditions are the same for all people. The reality is people experience pain differently, and it's based on their prior experiences with pain, the meaning that they attribute to pain, how they cope with challenges and difficulties. And so pain is individual, and none of us can tell another person what pain they're having or how severe their pain is. And this comes back to recognizing that pain is what the person says it is. A second myth is that if a resident can sleep or be distracted, they don't really have pain. The reality is distraction is actually a proven pain treatment. It can improve and reduce pain. So even though someone who's complaining of pain all of a sudden is watching television and not seeming to be in a very painful state, doesn't mean they're still not experiencing underlying pain, but that the distraction of TV is helping them to cope with it and to reduce it. So just because someone seems to be doing things that you might think they couldn't do if they were having pain, this isn't the case. In fact, we'll be thinking about ways to use distraction as a way to control pain, especially during acute experiences. Another myth is that there is not much we can do to help residents in pain. The reality is we have a lot of things that we can do. There are a lot of treatments from an analgesic perspective for both nerve pain and muscular pain. And there are a lot of non-drug things that we can do that can be very effective in helping residents to cope and manage their pain problems. Some other pain myths I want to talk about with you. Pain is just a part of growing old. The reality is that as we grow old, we do have more conditions that are painful, but it doesn't mean that we have to live with pain from those conditions. So yes, pain is more common as we age, but it is treatable and manageable. Another myth: doctors and nurses are the experts about pain. The reality is each person is the expert on their pain, and that's why assessment involves trying to get information from the resident about their pain, their experience of pain, what it feels like, the qualities of it, what they've done to treat it that's worked in the past, so we can integrate that into our plan. Professionals don't know everything about pain. They need to know the best ways of treating pain, but the patient is the expert about their pain. And finally, residents with dementia can't feel pain. The reality is, persons with dementia do experience pain. They can feel the pain sensation, and there are a few changes in the way that the pain sensation is moving from the area of injury to the brain. The difference is in the way that people with dementia interpret the sensation of pain or the feeling of pain. And that shows itself in the way that they show behaviors about pain that we need to be aware of and thinking about when we're looking for possible pain problems in those with dementia. Pain language. How do your residents communicate and describe their pain? We have learned in evaluating pain, if we ask older people, "Are you having any pain now?" they may say no. But if you use other words such as, "Do you have any soreness? Are you hurting? Do you have any aches? Are you stiff, cramping?" all of a sudden you get a positive response. "Yes, my hip is really hurting me," or "I'm so sore here." So we can ask about pain, but we need to follow up with other questions that may help identify a pain problem. So what is pain assessment? It is an approach to gathering information that helps us to understand if a resident has pain, and if so, what are its characteristics, which help guide our treatment plan, and how severe is it, and how is it impacting their life. So a pain assessment includes the resident's self-report always, if we can get an accurate report from the resident, even just acknowledgement that they have pain. So a response to a simple yes/no question can be helpful. A physical examination that gives us more information about locations and potential sites or problems that may be pain related. Observing for behaviors that may suggest pain is present. And getting a history about their diagnoses that we know might be painful, or whether or not they've had recent injuries or trauma, surgery, or if they're undergoing procedures that could be pain related. When do we do pain assessment? All residents in a nursing facility should have their pain assessed on admission to determine if they have pain when they enter the facility. Anytime that there's a change in their status overall, any changes in their condition, but particularly if there are changes in behavior that might suggest a pain problem. Anytime that pain is suspected, if they're experiencing a condition or an injury or a new diagnosis that we know is pain related, and at least quarterly as a way to continually monitor and evaluate for pain problems that need to be addressed. What is pain assessment? As I mentioned earlier, a comprehensive pain assessment includes information about a number of things. Pain intensity or severity. How severe is their pain, which is important to understand its impact and helps to guide treatment decisions. Where is pain located? This also can be helpful in identifying treatment strategies. If it's a local pain problem, we may be able to use some non-drug therapies to improve it. Pain character. How does the resident describe their pain? This is important to us because different words or characters help us to determine if the pain is nerve related or muscular related or organ related, and the way that we approach treatment is different. Pain pattern. Does it come and go? Is it intermittent? Is it continuous? Is it always there? Is there pain that's always there, but yet they have spikes of pain that come and go? These are important information for us to evaluate and to pass on to the prescriber in looking at treatment plans. And then really importantly for chronic pain, what is the pain's impact on function? Are they able to engage in activities that are important to them? How is pain impacting their participating in group activities, their ability to eat and sleep, interact with people that are important to them? These are all areas of function and quality of life that pain can have a major impact on. A little more information about some of the assessment characteristics. For intensity, we can ask for a rating of pain level or pain severity, and there are different tools that help us to do that. We can ask, where are you hurting? Where is your pain? To try to identify a location, or ask them to point to the area that's hurting. Character, asking the resident to describe the pain. What words do they use? And record those words and share those words. Pattern, again, how does the pain occur over time? Does it occur just with movement? Only when they're doing range of motion or daily activities? In the morning, in the evening? Is it always there? And impact on function. How does pain affect their ability to do the things that are important to them? So what is my role? You might be asking yourself. Well, all members of the nursing home team have an important part to play in pain assessment. And this slide just highlights what those various roles are. The nurse is of course the important person to do the thorough assessment, gather all of the information mentioned earlier, document and communicate the pain assessment to the prescriber to get a pain treatment plan and to assure that pain is managed. The prescribers may be a physician, may be a nurse practitioner or a physician's assistant, but it's their responsibility to participate in the assessment, perhaps, or to follow up once an assessment is done with prescribing a treatment plan. That may involve analgesics, or it may involve non-drug strategies, and following up and making sure that pain is managed. Other members of the team, whether you're a certified nursing assistant, a med tech, a social worker, chaplains, those involved in physical therapy, occupational therapy, even housekeeping, are observing and around older residents to be able to recognize indicators of pain and pain problems, and observing and reporting what you see to the nurse so that she can follow up with a thorough assessment is a really important part of the role that each member of the team in the nursing home plays in helping us to assure that our older residents' pain is recognized and managed. A little more detail about pain assessment for the certified nursing assistant and others. You are in such an excellent position because you have direct contact with residents. You assist with ADLs and other activities that involve movement when often pain behaviors show themselves. And you have regular contact with your residents to know what's normal for them, because often a change in normal behaviors or routine is a clue that pain may be a problem. So in observing, it's important to be trained on what behaviors to observe for that might indicate pain. Some examples are when your resident guards an area or braces an area. They may make verbalizations. They may say, "Ow, I'm hurting," or "help me," or any noises that groaning, moaning that might suggest pain. Grimacing is a key indicator, and really watching faces for expressions that help us to recognize possible pain is very important. Changes in behaviors play a key role in identifying pain problems in those with dementia who can't communicate. Certified nursing assistants should be trained to screen for pain or behaviors that may be a sign of pain using standard tools that have been developed and validated for use with this population. As I mentioned earlier, getting self-report is an important part of the pain assessment process, and there are a number of tools that are available that you can use in your nursing home for recognizing pain. One is a simple numeric rating scale where the residents look at a scale with numbers from 0 to 10, where 0 is no pain, 10 is the worst pain possible, and they pick the number that represents the severity of pain they're currently experiencing. A verbal descriptor scale can be a very simple way to get input from the resident about their pain. Even a scale that only includes 4 words, none, mild, moderate, or severe, can be helpful. And most residents can respond to this scale if they are able to verbalize at all. And sometimes a faces pain scale, where the resident looks at the series of faces and picks the face that represents how they currently feel. And finally, observing behavior. There are a number of scales that have been developed, and there are 2 that we're going to share in a future module that seem to be very appropriate and recommended for use in the nursing home setting. It's important to report all pain-related information to the nurse so that they can follow up with a more in-depth evaluation. So reporting verbally to the nurse in charge so that they can follow up, and to document in a written documentation tool that your nursing home uses to record what you're observing. So there's a written record that can be used from shift to shift to see what's happening with that patient. It's important for nursing homes to have a communication plan or rules about what should be reported, when it should be reported, how to report it, and in what format to report the information that you are getting from your daily interactions and observations of the patients that you work with. Other members of the team that are not nurses, all people have an important role to play in observing and reporting pain. Whether you're observing pain behaviors or other concerns that you pick up in your interactions with residents. If you suspect that pain may be a problem for a resident, you should report your information to the nurse. Share reports from residents if you hear a resident complaining of pain. If you observe behaviors that you think might be pain-related. Any reasons that you have for suspecting that pain is an issue with a resident. Communicate those verbally and document as is appropriate for your facility if there are places to do that. It's really important that we have a team effort in being aware and observant to recognize pain in our residents. Since our overall goal is to assure high quality of life and comfort of residents, pain is one of those big problems that can interfere and really impair the quality of life of your residents. So participating in the ways that you can as a part of your role in the team is really an important contribution that you can make to the care of the older residents in your facility. So the takeaway messages for this brief training are understanding that pain is common in older adults in nursing home, more common than not. So we have to be aware and looking for pain problems. It's important for all staff to understand information about pain and to learn the signs of pain and what we can do, you can do, to recognize pain in your residents. It is important that pain is assessed and documented on a regular basis, that pain is assessed and includes the key information that helps guide treatment and that helps us to follow up to see if we're making an improvement in that resident's life. Each of you can be a champion, a pain champion, by supporting the pain team in your facility, contributing to recognizing and gathering information about pain so that we recognize and treat pain in all residents in our facilities to assure our residents have the best possible comfort and quality of life. So I hope that you'll be a part of the team and contribute and get as much information as you can about what you can do to help.